Next on our agenda today is a panel presentation entitled Delivering Palliative-Based Care. Where are we now? So it's my pleasure to introduce our moderator, Kate Meyers. Kate is a senior program officer with CHCF's High Value Care team, which supports policies and care models that align with patient preferences, are proven effective, and are affordable. Her work focuses on improving care and quality of life for people with serious illness. Before joining the foundation, Kate worked for 8 years as an independent consultant, managing initiatives to expand access to community-based palliative care in California and to spread the lessons learned by pioneering organizations involved in this work. Please join me in welcoming our moderator and panelists to the stage. Kate?
Thank you so much. Hi, everyone. Is this on so far? There we go. No? Yes? All right, it's on. Hi, everyone. Well, thank you so much for that introduction. Again, I'm Kate Meyers with the California Healthcare Foundation, and I'm going to have each of our panelists briefly introduce themselves before we dive into our discussion today.
Hello, I'm Kathleen Kerr. I'm a healthcare consultant, and I've worked on a number of the palliative care initiatives sponsored by CHCF.
Hi, I'm Devin Dabbs. I'm the co-founder of Children's Hospice and Palliative Care Coalition. I've also had the pleasure of working with the Coalition for Compassionate Care for a number of years after we joined up our efforts in 2016. And I'm currently consulting with the Coalition on pediatric programming and education topics.
And I'm Judy Thomas, CEO of the Coalition for Compassionate Care.
Thank you all. So today we're hoping to have a conversation and to really frame this as a conversation. And I'm trying to model the informality of this by sitting with our panelists, also because I'm kind of lazy, so for an hour to stand would have been a little long. But we want to encourage you guys, we'll have a little bit of time reserved at the end for questions, but we do really, truly encourage you during our conversation, if something occurs to you, if you have a question, I know for some of you it's a little ways to go to come all the way up to the microphones, but please do. We really do encourage you to try to build this in as a conversation throughout our panel discussion. So a little bit of context before I dive into some questions for our panelists. Judy talked yesterday about some of the history and the context that the palliative care movement nationally and in California has kind of grown up within. And as Judy discussed a little bit yesterday, we've made a lot of progress in those years. Nationally, there's been a process of wrestling with the development of clinical practice guidelines around palliative care. There's been research studies that have helped us understand the evidence around the impact of palliative care that has shown the positive outcomes. And here in California, there's been a lot of work aimed at trying to reform payment practices related to palliative care and establish payment mechanisms for palliative care providers. And also in California, we've made some good advancements with policy changes related to palliative care. So with that wave of work that we've sort of been talking about as almost the first wave of palliative care work in California, the reward for all that effort and the reward for all that work has been that more seriously ill Californians have access to palliative care, both in the inpatient setting and in community-based settings, which is what we're really focusing on today. So with that first wave, we've seen a lot of success, but we also now, as waves and oceans behave, we have a second wave of challenges related to things like scaling services, standardizing services, and making sure services are sustainable over time. So we're here today to talk about some of those second wave challenges that we're in the lucky position to be dealing with now in California. And to talk specifically about how a few efforts and initiatives happening right now in the state are working to try to address some of those second wave challenges. So before we get to talking about that second wave, I wanted each of our panelists to talk a little bit about what they've observed in their years working on palliative care, about the progression we've seen specifically in community-based palliative care in California, sort of where we've been and what the first wave of work has accomplished. So I think we'll go this way down the panel. Start with Judy.
Thanks, Kate. So as I think about it, the movement is about taking a philosophy of care and turning it into a care delivery model. And I see sometimes that there gets confusion, that we're clear on the philosophy, and that's what we're moving forward, but the delivery model takes multiple different versions and forms. And in the early days, what I see as the first wave, it was really fundamental for this to get grounded in the inpatient hospital setting and recognized as a medical specialty. That made it legitimate. That put it into kind of where everybody gets trained. The hospital is kind of the center of training for our healthcare professionals. And now that we've done that, we want to move on to making it more available to people. And it was the work on pediatrics that really has informed in a lot of ways and triggered this second wave to a great extent, which I think kind of the big parts of it are the SB 1004 legislation and the CAIC, California Advanced Illness Collaborative consensus standards. So,
Thanks, Judy. Devin?
Yeah, I think actually when it comes to peds, to a certain extent, we're actually in phase 2 of phase 1. We have the pediatric palliative care waiver, which I think many of you are familiar with, which went into place in 2009. Subsequently, due to some restrictions that were placed on the home and community-based waivers by CMS, we made the decision along with DHCS to not go forward with the waiver in 2018. Now, fortunately, SB 1004 was in place, which, as Judy mentioned, was actually kind of came out of the waiver. And so we have that to fall back on. But as we'll discuss as we kind of go throughout this panel, there have been some real challenges to putting that into place for pediatrics. I think it provides some really nice opportunities for future, but we definitely have some work to do.
Thanks, Devin. Kathleen?
Yeah, to focus on the positive of the sort of the end of wave 1 or the first phase of wave 1, what I really see is more services offered in more settings and growing maturity of all those programs. So it is now the norm for large and medium-sized hospitals to have inpatient palliative care. How many of you are involved in delivering inpatient palliative care? Yeah, quite a few people. There's a couple hundred of those programs in the state right now. There's more than 100 palliative care clinics, either embedded in other types of clinics or standalone clinics. How many of you are involved in delivering clinic-based palliative care? Yeah, fewer, but still a lot. And there's over 116 at least, there's 115 organizations when I looked in February that are offering home-based palliative care in the state. And some of those have tiny services that operate in one little community. Others are spread across the state, maybe associated with the system. That's quite a few organizations that are offering that service that really, by and large, wasn't there 5-6 years ago. How many of you are involved in delivering home-based palliative care? Yeah, quite a few. So that is really, really good news that all that capacity is there. I think the other sort of hallmark of the coming to the end of the first wave is the attention to quality. There are, as of February, when I looked, there were 19 organizations that offer home-based palliative care that have Joint Commission certification in delivering home-based palliative care, and that's awesome. And there's also a growing number of organizations, not just inpatient programs, but clinic-based services and home-based services that are coming together to look at quality, and particularly through the Palliative Care Quality Network, that registry that folks use to look at their own outcomes and compare it to others. So I see more services and maturing services and sustained services.
Thank you. So what you all have described is a lot of progress and the achievement of some level of maturity of community-based palliative care in California. So what do you see as the biggest second wave challenges that we're facing now? And again, I think we'll start in the same direction. Judy.
I think, well, one of the biggest challenges is that palliative care at its heart is meant to be delivered in a way that our healthcare system doesn't work. Our healthcare system isn't structured to provide team-based care. Our healthcare, or reward it, it isn't really structured to provide home-based care other than episodic. Mm-hmm. We have a very, very fragmented healthcare system. Even with managed care or move to integration, I see that really starkly with the pediatric palliative care and the challenges with scaling that and expanding it. It's like our system is just, because it's so fragmented, palliative care falls and the ball gets dropped and the incentives are not aligned. There's also a lot of silos. Our policy structure is based on licensure categories, and benefits follow those categories, and the laws follow the licensure categories, and we think in silos. We have not created a system from a policy or reimbursement that looks at the patient's needs, that looks at that rainbow that Katie Butler showed us yesterday between active living and active dying. And that would be my dream, you know, if I had a magic wand, is to totally restructure the policy structure to base it on the patient's needs and the best care possible and the best setting they should be receiving those services in. I think another challenge that we see is that when we're starting these programs, the low-hanging fruit where it's more clear that there's the financial case are people who are very late stage in their illness. So we get this blurring and this confusion, again, as we try to say, you know, palliative care is about serious illness and not be talking about and aligning or connecting it with hospice. But the patients often look a lot like the hospice patients. So that's part of a challenge as well. And then, of course, the other things that have been covered and will be covered more. So,
Thanks, Judy. Devin, how about you? What would you say are some of the biggest second wave challenges or end of the first wave for pediatrics?
For pediatrics. Well, I think number one is sustainability. I mean, we have to create a system that actually pays for the cost of care. I mean, traditionally, pediatrics has been dependent upon philanthropic dollars, community support in order to maintain pediatric programming. And so, you know, I think our biggest challenge right now moving forward with this new Medi-Cal benefit, which again, I think there are lots of opportunities there, but I think it's creating rates which actually are equivalent to the cost of care. So at minimum, agencies are in the black. We have some capacity issues, but I think that capacity could be met if people felt that they could create a sustainable program. And what is different with pediatrics and adult programming is we don't need a dozen agencies in a county in order to meet the need. The population is much smaller, but it needs highly qualified providers who understand children, understand family dynamics and how that works within pediatric palliative care. So I do strongly believe that if we can create a sustainable funding stream, that we will have enough agencies that will be able to step forward. In many counties, we only need one agency to meet the needs of the children who would benefit and would qualify for palliative care. But the challenge has been that the agencies just strictly cannot afford to keep those programs going forward unless they've got very strong community philanthropic support in order to do so. I think that to Judy's point, I think ensuring that quality is there as well in terms of the providers, making sure that we have some strong oversight. You know, it's a complicated issue, but I strongly believe that we can figure it out. But we really have to work together to first ensure that we're actually getting paid for the care that's being provided.
Thanks, Devin. Kathleen, how about you? The biggest second wave challenges?
You have a pediatric groupie over here. who's
Giving some
clapping.
clapping.
People.
Yeah. Some thumbs up.
I'd say one of the biggest second wave, challenges for me was nobody warned me there would be a second wave of challenges, which is really kind of crushing. I think that the biggest challenges that I see sort of globally in the adult world is that we have this amazing network that's been built. All of you and all of your chums who didn't manage to make it today that are delivering these services in so many places, but are available to deliver these services in so many places. But right now, I would say that the capacity is being underutilized, that it takes so much effort to find the patients who need the services, to get permission to see them, engage with their other providers, and then have the patients and families understand what these services are and how they can help them, that's a lot of effort. And the result is that the number of people served is less than what could be the case if those services were being utilized to their full capacity. I think there are very real-world sustainability issues attached to that, where there is a certain amount of resource that's required to maintain a service. And if the volume doesn't catch up eventually to that investment, programs are not going to be able to afford to maintain that capacity indefinitely or for years if they're taking a loss. I think the other issue, on the one hand, there is a recognition that there's growing attention to quality of service. And there's a movement towards understanding how to measure quality, like what would we look at that would tell us that the care that we're giving is good. But I would say that there's been so much focus so far on building networks, building capacity, trying to identify patients, that there hasn't been quite yet as much attention to quality as there needs to be, in particular to really core areas like, are we doing a good job with symptoms? Are we doing a good job with communication? Are we doing a good job with coordinating care so that we're not duplicating services or stepping on the toes of the other folks that are also trying to help these patients and families? And the quickest way to undermine the gains in increasing your referral base is to do a bad job with the patients that are referred to us. So those are what I would see as sort of the top of mind second wave challenges.
All right, so we have our work cut out for us.
Yeah.
A few
Almost
challenges. So we talked, within this panel, we wanted to cover a few different particular initiatives happening right now that are trying to address some of these challenges. And so we'll be sprinkling throughout the discussion each of these initiatives. We've begun to talk about pediatric palliative care and the integration of that into SB 1004. I wanted to talk specifically about SB 1004 just a little bit, and because I know we have a pretty diverse audience in the room, in case folks don't know, Senate Bill 1004 was passed back in 2014. It went into effect January 1st of 2018. It originally addressed a requirement for Medi-Cal managed care plans to provide community-based, or actually not just community-based, palliative care services to a specific set of patients based on eligibility, disease states, and some other criteria. In December of 2018, SB 1004 was expanded to include pediatrics. So when we're referring to SB 1004, we're talking about the Medi-Cal managed care population. Medi-Cal in California covers a third of our population, so this is obviously a big deal. And as far as I know, SB 1004 was the first of its kind requirement of a Medicaid program in the country, and it is being watched by many other states across the country who are looking at that as an opportunity to similarly expand services in their states. So Judy talked a bit earlier about SB 1004, and Kathleen, you've been involved for some time in technical assistance to the Medi-Cal managed care plans and community-based providers doing this work. Can you talk a little bit about how you think SB 1004 has influenced the community-based palliative care landscape so far, and how you've been working with those organizations on some of the challenges that you've just described?
Sure, yeah. Any Medi-Cal managed care plan representatives in the audience? Hey, anybody, any providers in the audience involved in delivering SB 1004 palliative care? Yeah, that's one of the big influence points, is that of those 115 organizations that we saw that are delivering home-based palliative care, 53 of them we found have contracts with Medi-Cal managed care plans to deliver SB 1004 palliative care. So what that tells me is that the delivery of home-based palliative care to this population that had no access before is central to delivery of home-based palliative care to everybody else. And anything that's done to help organizations generally provide home-based palliative care is going to benefit those very vulnerable individuals that rely on the safety net. And it works the other way too. Anything that we can do to make SB 1004 palliative care more sustainable and of higher quality is probably going to have a ripple effect and help everybody else also. So it truly is, I think it's a huge part of home-based palliative care delivery now. The big issues that we saw come through after sort of looking back at the end of year one of SB 1004 implementation how do you identify the patients who would benefit? It's a huge challenge because this is going beyond that theory of what is palliative care to how you deliver a defined benefit, and you need to find the people who are eligible for it. And it turns out that's kind of complicated and hard. So that needs to be figured out. And again, I think some of the work that's being done there with the SB 1004 population is helping in other palliative care delivery as well. There's also a lot of work that's being done to help to identify the menu of possible interventions that would help with engaging referring providers. Our dear colleagues who are oncologists and primary care physicians and pulmonologists and cardiologists who are taking care of really sick people, who many of whom still do not know that there is a difference between palliative care and hospice. And there's an equal number who aren't entirely sure that palliative care is going to help their patients. And there's many who are kind of worried that palliative care isn't going to help them, that in fact it's going to make their lives harder, because here's another service they have to coordinate with and support in delivering more stuff to their patients. And so there's a lot to think about there, a lot to be compassionate about there, and a lot to learn about there. And there's also a lot of issues around how do you communicate to patients and families about what palliative care is, again, in a group that often doesn't know the difference between palliative care and hospice, that are worried about having other things taken away from them if they accept this other support. And so there's a lot of challenges that have been identified, challenges where we're feeling the effects of them now, but also a lot of work that's being done to identify promising practices and begin to disseminate those.
So we've talked a bit, Devin, you already talked a little bit about the transition from the pediatric palliative care waiver into palliative care responsibility for pediatrics folding under SB 1004. Is there anything else you want to say now about what the inclusion of kids under SB 1004 means, and what some of the, in general terms, because I know this can get pretty technical, what some of the differences are between what was available and required under the waiver and what's available and required under SB 1004 for kids?
Sure, yeah. So first off, I'm just going to take a tact from Kathleen's playbook. I'm curious, how many out here are actually providing home-based pediatric palliative care now? They're under the waiver.
Oh
Yeah.
It's a lot of you.
Who's doing it today?
Bravo.
If
Love it.
Yeah.
All right. So I'm not going to tell you guys anything you don't already know, but for the rest of you.
Yeah.
So once the decision was made not to move forward with the waiver, we worked very closely with DHCS to create eligibility requirements within the all-plan letter for SB 1004 that were very specific to children. The original criteria was very adult-centric because we had the waiver. So we felt the kids were covered, their palliative care needs were covered under the waiver. But once the waiver was discontinued, we had to find a way in which to leverage SB 1004 to provide those services to children. So the good news is the eligibility criteria that was actually originally adopted and included within the all-plan letter is very broad. Unlike the adult population, it is not disease-specific. It talks more about criteria related to progression and the stage of the illness. So the challenge is that while I think DHCS remains committed to creating a comparable benefit under Medi-Cal to what was available under the waiver, we're challenged because two of the key that came out very funny. All right, I'm going to start this all over again. Two of the key services, I don't know why that was so hard to say. Maybe it's just because I'm so frustrated that we can't get these paid for, were expressive therapies and respite care. And so without those two services, it's very difficult to really replicate exactly what was available under the waiver. Some of the other services that are included with SB 1004 marry well or somewhat mirror what was available under the waiver, but there are also differences in terms of how they're delivered. For example, care coordination, which was under the waiver, was very intensive. Families got a minimum of 4 hours in the home visit. sometimes additional hours, depending if there were other things going on within the family, certain dynamics that required more time and attention. They also had someone available to go out with them to doctor's visits and to kind of come back and help them reflect and process on what they had heard. Care coordination under SB 1004 is not as intensive. Another piece that is different was related to the 24/7 on-call nursing. Any of you who have a child or have been a child, you know that things always go wrong in the middle of the night, right? So 24/7 on-call nursing for our families was really important. And while managed care plans often have 24/7 nurse advice lines that families can call, it's not the same as being able to call your provider, the one who's actually working with your child, knows your child, and to speak with someone who, if not directly part of your team, is very aware and has the information and is conscious just of where your child is in their progression, what treatment they've been receiving, what are some of the challenges you've been facing as a family. So, I think in response, just to wrap up, that there are a lot of opportunities. SB 1004, the health plan letter, allows for greater medical management, which was not available under the waiver. So that, I think, is a great opportunity. But the intensity of in-home care and attention that the families were getting under the waiver is just not currently available in terms of how we're administrating SB 1004. One piece that from a managed care plan perspective that I think can be helpful, and I know some of our providers have been somewhat successful in doing this, is instead of going fee for service, is to create a bundled service benefit or rate that allows them then the flexibility to really work with the families and to create a plan of care that addresses their needs and may include some of the services that, while not directly reimbursable by Medi-Cal, can be covered under this bundled service rate.
Thanks, Devin. So, applaud. That's good. Bring it on.
Whoever you are, thank you.
So just before we shift to talk a little bit about the California Advanced Illness Collaborative work, just to sum up a few observations, it's from what you guys have been describing. Obviously, we're at a different stage of development for adult palliative care and pediatric palliative care, which means there's different challenges that are faced in both of those realms. With adults, it sounds like from what Kathleen was describing, we're now at a point where we actually have a pretty decent number of providers and good capacity, but there's challenges getting patients connected to services early enough and appropriately. And with kids, there aren't yet enough providers, though we think with appropriate reimbursement that could happen. But right now, they're kind of concentrated in a few geographic areas. We'll take a pause on thinking about that specifically for a minute and talk a bit about one of the issues we brought up as a second wave challenge around standardization. And Judy, we've talked a lot over time about the challenges related to lack of standardization in community-based palliative care. We've seen that though there are great national consensus guidelines on what high-quality palliative care looks like, we see a lot of variation in real life. Both in terms of what palliative care teams look like, what services are provided, what patients are considered appropriate or eligible, what different payers will pay for. And can you talk a little bit, Judy, about how you see that variation having presented challenges to the field and how the work that you guys have led around the California Advanced Illness Collaborative Guidelines and pilot helps to try to address that?
Yes, so where to start? Anyways, what we were finding, and kind of through some of the work that the California Healthcare Foundation did to fund payers and providers coming together to develop palliative care programs, it was showing that it was kind of like you saw one program. They were boutique programs that were developing for particular patient populations, which shaped the team, which shaped the reimbursement. It just wasn't scalable. So around that time, Blue Shield came to the coalition and said, we think maybe it's time to start developing some consensus standards in the state, really around the delivery of palliative care. There's the national consensus standards, which do a beautiful job of really laying out kind of the clinical aspects of what should be provided clinically, but what does that look like? How do you deliver it? And our goal with the CAIC consensus standards was to create a floor so that if a palliative care provider was providing palliative care consistent with that structure, that they could contract with multiple payers, that multiple payers would expect the same structure of the team members, the education, the quality, and the payment. And again, so that your relationship as a provider you'd be able to get enough critical mass to sustain that program. So that was the basic concept behind it. And we are now in the phase, it was happening simultaneously with SB 1004 moving through the legislature. And so before the consensus standards were finalized, we did a crosswalk between the two to make sure that they were supporting each other. So really, the CAIC is a complement to SB 1004 that would apply to, on a voluntary basis, it's not in law, but on a voluntary basis to everybody who's not on Medi-Cal. So that's the basic concept behind it. And we are doing a pilot now with the consensus standards in SB 1004 in Sacramento and LA.
Thanks, Judy. And a big part of what we're hoping to learn from the CAIC pilot has to do with some evaluation activities that, Kathleen, you're very extensively involved in. Could you tell us just a little bit about what we hope to learn from those evaluation activities and what the time frame is for that?
Sure. So the time frame, we'll start with that. I think it's going to be mid-2020 is when we'll have some results out. And the goal of the evaluation of the pilot of the CAIC standards is to try to see, do they help? You know, they are a floor. It's a set of minimum expectations. And like SB 1004, what you see is there's folks who say, okay, we're going to start with that. There's other folks who build on it, require more services, expand the services to more populations, have different rates. And so the standards can eliminate some variability, but not all variability. It's funny, in the group that developed the standards, as we think about how they're being used, the main goal of them is, the shorthand for that is solving Jill Mendlin's problem, which is she has a palliative care organization that had 8 different contracts and 8 different sets of expectations. And so generally speaking, the idea across multiple domains is, are these standards solving Jill Mendlin's problem? And really a more precise way to thinking about that is, do the standards facilitate provision of community-based palliative care? Is it easier to contract with multiple payer partners if you're working from a starting point of a minimum set of standards? Is there anything in those standards, anything having to do with how the eligibility criteria are spelled out, or who should be on the team, all those sorts of issues that are in the standards? Is there anything about those that make it easier or harder to actually go from a concept of palliative care to a delivered service? Are some of those hard to work into an operational perspective? And so any difficulties or facilitation with implementation that comes from the standards. That's one set of learnings. Another set of learnings is, are the financial outcomes sufficient to make the services sustainable both for the payers and for the providers? So if you're offering palliative care as defined in the standards or as defined in SB 1004, is there alignment between the amount of revenue that you're receiving and the cost of what it takes to deliver that care, both from the perspective of the entities that are delivering care and from the perspective of the payers? And we're doing a lot of work with a quantitative evaluation looking at those outcomes. And again, we're going to be looking for lessons learned of, are there ways that the standards should be tweaked to sort of achieve better balance across more organizations? And finally, the third way that we're evaluating, the third area that we're evaluating in the pilot is, well, what about the folks that are receiving these services? Are they what they need? Do they appreciate them? Do they feel that their lives have been made better because they receive these supports? If we have a service that can be delivered for the right amount of money and the payer and the provider are happy, if the patient and the family and the caregivers are kind of like, well, that was kind of more trouble than it was worth, then we haven't really accomplished anything. So 3 domains: operational, financial, and from the patient and family perspective, all wrapped up with a bow on it. In a year or so.
Mid-2020.
Mid-2020. Yeah.
Stay tuned. All right, so it sounds like all of these efforts we've been discussing, the SB 1004 requirements, the California Advanced Illness Collaborative, and pediatric palliative care, all of them require or really benefit from effective collaboration between organizations. I mean, some of that's fairly obvious, collaboration between a payer and a provider, for example. But that's sort of just the beginning of how we think about cross-organization collaboration that will help this work move forward and reach its full potential. Can you all talk a little bit about kind of what you see as the dangers of maintaining our usual silos, or how collaboration across different kinds of organizations, not only the payer and provider, can help? Kathleen, you want to start?
Sure, always. Yeah, what you just said. It's really
Done.
in more ways than is typical. There are incredible dangers and risks and costs to not collaborating, and there's quite a bit of benefit to be culled from collaborating. So I would encourage anybody who's living in an area where there are multiple providers of palliative care and also payers where there are multiple, even if you're competing for that market, there are benefits to working together that still allow you each to accomplish your goals. And I think a lot of this is because so much of what has to be accomplished has to do with culture change. Mm-hmm. So if everybody is encouraging the same providers to refer their patients who might benefit and creating incentives for getting education, that's work that can be done together, and then everybody benefits. If there's collaboration in educating patients and families about the benefits of advanced care planning and the benefits of palliative care, and even, oh, what the heck is that? Oh, and it turns out it's not hospice. That education can be done by people that are technically competing, mm-hmm. and it's to the good of all. So there's quite a bit to be accomplished in very specific activities having to do with community-based palliative care. There's also benefits for engaging organizations that would maybe have contact with individuals who are now seriously ill or who may become seriously ill later, to provide those services that maybe don't reach that threshold of what's currently in SB 1004. What can be done around primary palliative care, and what can be done with better collaboration with FQHCs and social service organizations to meet these needs or identify them, and do that at a point in time where it's early enough to create some comfort with issues and comfort with need, and then promote appropriate referrals to services later. Mm-hmm. So I really think that this is the next place that we need to go, is how can we work more effectively across organizations to take care of these people for a longer period of time. That will help with utilization. It will also help to make these services more sustainable, because you're not trying to provide hospice care if you're a palliative care program, and you're not trying to provide palliative care if you're an FQHC.
Thank you. Judy or Devin, do you want to just briefly say anything about the role of coalitions as you see it with respect to the cross-organization collaboration before we move to closing and some table work? Anything else?
Well, I'm a big believer in coalitions. I guess that is obvious. I think, speaking just specifically to pediatrics, collaboration has always been a key piece of the work, because there are fewer pediatric providers, especially related to community-based care. So kind of learning from one another and sharing resources has been critical. I think that getting people to the table to actually talk about what it is that we're looking to achieve, but primarily the key piece remaining focused on who it is that we're looking to serve. There has never been a conversation that I've had in a group in which people may have different ways of getting there and what this is going to look like. But if our intention is to ensure that children have access to home-based palliative care services, we've seen the benefits of that through research that was done on the waiver. We saw a 50% drop in hospitalizations. We saw a more than 60% drop in length of stay, from 16.7 to 6.2 on average. And we saw a huge fiscal benefit in terms of better utilization of our healthcare dollars. We saw a savings of over $3,000 per month per child. And in my opinion, more importantly, we saw families' satisfaction increasing at 100%. Families loved having these services, loved having access to this care. They no longer felt isolated and alone. So when we talk about collaboration, a key piece of that is ensuring that the families in our communities have access to community. Because so many times they are isolated and alone in their homes without this care, without these connections. So, yeah, I fully believe that we have an obligation as advocates and as providers, and as just individuals in the world, to do what we can to come together to serve this population.
Thanks, Devin. So we're going to move in a minute to some table-based conversations, but before we do that, I just wanted to see if any of you had any kind of final comments or observations, anything else you wanted to share with the group about the second wave challenges, or any parting words before we get into a little bit of table work and some Q&A.
Well, I'd just like to add that I can't think of another area of medicine that was created through movement. And so what we're doing here is very unusual, and I think that goes to the need to collaboration. And in a way, the pre-wave before the first wave was the hospice movement. And so we're trying to learn from that. So hospice did come out of this grassroots movement, but it came down from Medicare that here's the benefit. And that served us well for many years, but now we're saying, you know what, those restrictions, because it came down from Medicare as a benefit, and they didn't want to pay too much, and they didn't want all these people getting these services, it doesn't serve much the needs that we have today. So we're trying to go through this way of that's blending the best of policy and regulation and consensus across a fragmented system that's moving to the future of healthcare reform. And palliative care embodies all of the principles of healthcare reform. But because we're doing it as a movement, I mean, all of you know this in your gut. That's why you're here, because we need that movement, we need that collaboration to be able to reach that goal of what we're trying to, that future vision that we all have.
Thanks, Judy. Any final words, Kathleen or Devin? Okay. I think we wanted to make sure to save some time for table work. So what we wanted to do is just take 5 or 7 minutes or so to have you talk with folks at your table about anything you heard that resonated or that is different from your own experience, about what the current challenges are or the second wave challenges are. And also, if you have any questions for us, think of those with your group, and then we'll have a few minutes for folks to come to the mics if you do. So we'll take about 5 or 6 minutes for table talk. All right, this is a lively discussion group, which we greatly appreciate. We have been told that we need to be done with our session right on time at 10:55. So we wanted to invite any comments, questions, observations, things that you talked about at your table that you'd like to share with the group. Please come on up to a microphone. Don't be shy. Thank you, Terry. You're first. Come on up.
Hi.
All right, folks, we're going to hear a question and get responses from our panelists.
We
Thank
have
you.
a lot to celebrate at this point, and so congratulations
Speak up a little bit,
to
Terry.
everyone. But I want to add to Kathleen's challenges for the second wave. And at this point, home-based palliative care shares an Achilles heel that long-term care has had forever, which is the exploitation of caregivers, both unpaid family caregivers and a direct care workforce that's paid poverty wages. Of course, it's just a coincidence that they're mostly women of color. But there has been movement in California to focus on caregivers in new ways other than just preserving IHSS. So there's now a requirement for hospitals to identify caregivers at discharge and assist. How well anybody's doing that, who knows? One thing we could do, I think, as a collective is add caregiver assessment, research-based caregiver assessment, standardized to all of our home-based services, and then obviously support the political movement in California that I think is setting a standard for the nation.
Thank you, Terry. Any comments?
Could I just add to that? Let's make sure that we include families who are caregiving for children, because most of those caregivers have been caregiving for decades on their own.
Thank you.
One final thing I'll say about that, I mean, it's such an important point, is, the SB 1004 had a list of minimum services that had to be delivered. When we did the check-in at a year in, 85% of the plans had increased the number of minimum services that they expected from their providers, and a substantial portion of those included as one of the minimum expected services was a formal caregiver assessment. So I think it's being heard, and it's on the way to being folded in.
Oh, that makes me so excited.
Thank you. Over here.
So I'm a palliative care physician and a hospice doc, and you had wanted to make a clean distinction between palliative care and hospice and sort of that, clear line. I would really like to blur that line because the mean length of stay in hospice is only days or a week, and it's clearly an underutilized service and that people would benefit from it long before many or most people ever get on the hospice service. And it is true, they lose benefits. They lose whatever transfusions it might be, some hormonal chemotherapy medications, or those, so they are needing to give up some things. And if we could blur that and have greater leniency between and create a dotted line, I think it clearly would serve, the people that we're serving.
Yeah, it's the, Judy, you probably have ideas on this as well, but it's that distinction between getting people the care they would most benefit from in the setting that's right for them at the right time, and layering over that benefits that pay for certain things. And as long as those two aren't identical, there are going to be some significant pluses to appreciating the difference between the two. But the ideal scenario is when it's seamless, it doesn't matter, you don't know that you're enrolled in any program, you get palliative care, you just get palliative care. And whether that's through a hospice benefit or a home-based or a clinic or part of your primary care, yeah, let's do that. I vote for that.
Can I just add a quick note on pediatrics around that, though, is that, for those of you that aren't familiar with pediatrics, we do have through the Affordable Care Act concurrent care, which actually enables a child to enroll in hospice. and continue to receive treatment, whether it's disease-directed or curative. So I think kind of creating that transition, that's why I believe home-based palliative care is also so important, as these are really difficult decisions that we're putting forward to parents that they have to live with for the rest of their life. So the sooner that we can get in and start that relationship and start having those conversations with them, the more informed, prepared, and supported they feel in making sometimes some very difficult decisions.
Thank you. So we have about 4 minutes and 4 questioners, so we're going to do our best.
Okay, thank you. My question is actually in 2 parts, and it's about palliative care professional workforce. And I can't help but notice that there was very little said about that during our time. I'm wondering, number one, why is it not more recognized as a problem for us going forward? Number two, I'd be interested in what your thoughts are. Not just why isn't it recognized, but how are we going to address a workforce which is far understaffed? Yeah. Thank you.
Well, I'd like to give a shout out to CSU Institute for Palliative Care, wherever those team members are here. That we're fortunate in California that through the CSU system, there is a really robust education training that's developed and available online for additional continuing education. There's also PACHETA, that's the bill at the federal law that would help increase our hospice and palliative care workforce. So that's comments that I have. So it is important, and there are some initiatives underway, but we do need to be paying attention to them because none of this is going to happen automatically.
The other piece I would just add to that is as we start to move statewide with this benefit for pediatric palliative care, that we are going to have more providers who are more comfortable in providing care for adults to transition to provide some level of care for children, especially in these outlying communities where we just don't have the staffing to support a full pediatric palliative care team and probably don't even have the population to support a full pediatric. But we need to still provide care for those kids in those communities. So CSU is actually another chata doing some training around that. NHPCO has some training around it. There are lots of opportunities to learn how your competencies as an adult palliative care provider can transition over into providing support for children.
Thank you. Any other comments? All right.
So I'm going to give a few kudos. With the moral support of partnership healthcare plans, with the practical suggestions from Tori Fields and Blue Shield, and with Kathleen Kerr's financial analytics, we were approved to start a home-based palliative program in our service area, regardless of payer type. So, but it's with a little bit of sadness because some percentage of the palliative care services that we're going to provide, and I don't know whether that's 50%, 70%, comes because of primary care failure, as what you said. As difficult it is to measure palliative care on a dedicated palliative care team, it's even harder to measure that and the impact in a primary care setting. And so I'm looking for some guidance on that.
How to measure quality and impact of primary palliative care?
And even the efforts of what primary palliative care should represent.
I think we have 0 minutes left. Let's chat. I think it's really important, and it ties into this issue of do you measure the impact of a service, which is important to that entity that's delivering the service, but more importantly is how do you measure quality and how do you set benchmarks across the continuum and what was caused by earlier versus what was caused by later. So let's chat.
And it sounds like, I'm sorry, we probably don't have time, but we are here all day, so we're happy to chat with any of you. Yeah. Thanks. Sorry, Jim.
Thank you, everyone.
I just want to thank the panelists for their expertise today.
And Kate.